Thank you so much for everything.
Today we want to continue our education, specifically talking about the pancreas. Okay. And we're going to go through some of the things that really on a residence level, what we need to know on a very high level. It'll help a lot with the exams. And it'll make you clinically very good. So the way we're going to do this is we're going to let you guys look at the question, and then you're going to use the chat to put your answer A, B, C, or D, and then we'll explain and go through. So let's start with this question. It's a very good question to get started. Let's use the chat tool here to put our answers in. And you could all see and read the question. Young female coming in with a little bit of a fever, tachycardic. It gives you the labs, and they want to know what's the next step. So let's use the chat. So some of us are saying CAT scan. Some of us are saying antibiotics. That's exactly what they want, guys. They want you to get confused. They want you to get very confused. Some people are saying upper quadrant ultrasound. So they're all right answers, but in different scenarios. Some of us, okay, so we have all the different answers. This is great that we're going through this. This is really good. This is really good. Okay, so let's explain. Okay, so in this case, the answer is going to be C, CAT scan. Why? Why CAT scan? So the exam is giving you a patient who comes in with a very typical presentation for acute pancreatitis. Now, they're tricking you by telling you they have a fever. Don't pick antibiotics. Fevers can occur with inflammation like the pancreas. Now, they're giving you a lipase, which is cheap. This is not a good lipase to diagnose pancreatitis, right? You need 2 of the 3 criteria. You need epigastric pain radiating to the back, which we have. You need either a lipase 3 times the upper normal limit. So upper normal limit is like 80. So you need 3 times 80 is like 250, minimum 250. But if you don't have the lipase you need to still make a diagnosis, guys. You do not have a diagnosis of pancreatitis. Therefore, answer is CAT scan. You got to clinch the diagnosis. Now, try this question. A lot of you are getting at this question. Same exact question, but here they're giving you the lipase, which is indicative of acute pancreatitis. And now they're asking you next step. Let's take some in the chat. People are still saying give antibiotics. Guys, do we treat pancreatitis with antibiotics? Some of us still want a CAT scan. Once you diagnose pancreatitis, guys, you do not need a CAT scan. You needed it to diagnose. Once you have a diagnosis, you have 2 of the 3 criteria, you do not need a CAT scan. This is the favorite on the exam to trick you. They want to know, they want you to understand, like Yusuf, like Katerina, that here you have to get the etiology for the pancreatitis. What are the common etiology? Alcohol and gallstones. You need to rule out gallstones. How do you do that? Answer is B, right upper quadrant ultrasound. All patients need a right upper quadrant ultrasound to rule out stones. Now, the reason why here you didn't need ultrasounds is because you didn't have a diagnosis yet. Therefore, you needed a CAT scan. But once you have 2 of the 3 criteria, you move on to right upper quadrant to get the ultrasound. They love this. They love this on the exams. A little bit more about pancreatitis. IV fluids, usually lactated ringers. Analgesics, usually hydromorphine is better. We spoke about needing a right upper quadrant ultrasound. And the key is going to be oral feeding. Oral feeding is going to get the patient better faster, and the guidelines recognize the need for oral feeding, and particularly less than 24 hours if they're able to tolerate it. If not, you want to do NG tube, enteral feeding, much better than peripheral feeding because of a high risk of infection, and the exam loves to test that point. Okay. Some other types of pancreatitis, autoimmune. You got to get an IgG4. Don't forget about the prednisone for treatment. Drug-induced pancreatitis, look for didanosine, one of the big heart therapy medications. Some of the IBD and valproic acid cause it. Hypertriglyceridemia induced. You diagnose with 1,000 triglycerides over 1,000, and they're going to need insulin drip in the ICU to get their triglycerides down. Okay. Let's take this question. It's not exactly on pancreas, but it's very close to pancreas. It's a favorite on the exam. Let's try to take this question. Okay, so this is an exam favorite. And the reason this is a favorite is because they want people to think, they want you to think one of two things. This is a 34-year-old. What's the diagnosis? Let's start there. Anybody want to call out? What's the diagnosis? I think we all know that it's positive Murphy's, gallbladder edema. It's going to be acute cholecystitis. They want you to know that she's pregnant, right? That's the trick here. They want you to either think just conservative management or a lap chole after birth. That's wrong. The guidelines, its answer is B. The guidelines are very clear with women who are pregnant, who have acute chole. Answer is lap chole before discharge because they have a very high risk of returning with a common bile duct stone or acute cholangitis. So it's an exam favorite, an absolute exam favorite. Let's try this, which is a very classic question they love to ask, specifically for ICU patients. Let's take a stab at this, guys. So this is another example. What so Anit, you were all over this. You were all over this. So what they want you to understand is this is a patient who has very, very clinical picture of stones. ICU for sepsis. She has a lot of clinical picture for stones, but the ultrasound shows no stones. So a patient in the ICU, who's on TPN is a very high risk for acalculous cholecystitis, which means gallstones, but not really stones, just sludge. And they need a chole tube because they're not stable enough for ERCP. And the answer is cholecystostomy tube. It's very common in patients who are in the ICU on TPN and they need a chole tube. The exam loves to ask that. They are not good candidates for surgery or anything like this. Let's move past this. Let's tackle this question, the very classic question they like to ask. It's a little bit hard and it talks about some of the complications of pancreatitis. Okay, so a lot of us are saying we have a little bit of a mix of things. Some of us are saying it's you do necrosectomy, RCB. So the answer is what? So what is this, guys? What are they explaining? This is a patient who comes in. Yes, Gayanti, excellent. This is what we call a pseudocyst, greater than. She was admitted what they say here about a month ago. So greater than 4 weeks. Okay, greater than 4 weeks. Now it's coming with a well-defined wall, but there's no debris. No mass, no debris. It means it's a simple pseudocyst with no symptoms, asymptomatic. Observe. Answer C. So this is a pancreatic pseudocyst. Okay, so let's spend a minute or two talking about the complications. Okay, and we'll right here are the complications. So there's within 4 weeks, guys, the things we need to know within necrotic collection, like usually within a few days, or it's acute peripancreatic fluid collection, based on if there's debris or not. Obviously, acute necrotic collection, you'll see necrosis. Acute necrotic collection, you need to drain it endoscopically. If it's acute fluid, you monitor. Now, greater than 4 weeks, it's either a pseudocyst or walled-off necrosis. If it's a pseudocyst, there's no debris, conservative care, unless they're symptomatic. If it's walled-off necrosis, you need surgical drainage. And that's what the exam could test you on any of these 4 complications, status post pancreatitis. They love to test this. One quick question on we'll end up on this question on chronic pancreatitis. Let's take a stab at this, guys. Excellent. So Anit and Katerina, you were all over this. So this is a patient with chronic pancreatitis, and they want to know, how do you treat pain in pancreatitis? The answer is tobacco cessation. Stop smoking, stop drinking. These patients do better. NSAIDs are actually the first-line therapy. Naproxen is first-line therapy. You don't want to hold that. Pancreatic enzymes are good. They do not help for pain. They help for diarrhea. So the answer is tobacco cessation. Chronic pancreatitis, first line, cessation of alcohol, tobacco, always the right answer. Second line, amitriptyline, nortriptyline. Enzymes help with diarrhea, not for pain. Excellent. I think that's a very good quick summary of pancreatitis. They love to test this on the exam. I want to turn it over to Arathi for some a few words.
Yeah, thank you, Dr. Weissman. This is also a wonderful session like we did earlier. So can you just tell us about your new cardiology telerotation, which we are going to start on 14th of
Oh, yeah. Sorry, yeah. So if anybody's interested in cardiology or even internal medicine, we have a physician who's affiliated with St. Joseph's Hospital. It's a great teaching hospital. He does a cardiology telerotation all on Zoom. You do not need to come in person. It's on Zoom. Meets twice a week, and then you join a didactics of a program another time. So it's 3 times a week. And anybody who's ever done with us tele or research, there's a big discount. So just talk to Sarthi about that. It's an excellent telerotation in cardiology that we're launching for the first time this month. So feel free to take advantage of this.